the long virtual struggle back from the tea break as people saunter back in to that raise. Really good start to the first half of this meeting, and thank you so far for your engagement. Please do keep the comments coming in the chat. I shall try to be as generous as I can with questions and comments verbally, but the chat is always available, of course. So we will move on. I'm just going to remind us that this meeting is very much framed around 21st century service transformation. I think what we've heard so far has been both challenging, thought-provoking and informative. So in that vein, welcome to Paul Stevens and Emily Stewart, Chair and Head of the South East Clinical Senate. I did promise you additional Senate representation, so we've got the North of England joining the South of England, so it's good to do the North-South partnership. And I'm going to hand straight over to Paul and Emily.
Great, thank you very much, Martin, and good afternoon, everyone. Can I just check that you can hear me okay?
Yep.
Brilliant. So hopefully we won't have a north-south divide by the end of this. So thanks for inviting us, and we've come to you this afternoon to talk about the Senate Clinical Codependencies of Acute Hospital Services document. And what we're going to do is I'll talk for about 14-15 minutes to some slides, which I'll just start sharing. And then both Emily and I will take questions. Let me just put that up. Right, is that on slideshow for you guys?
Yep, it is, thank you.
Brilliant, okay, thank you. So this report was originally published back in 2014, and it was produced at the request of the then South East Coast Commissioners in response to the major focus that there was at that time on the future role of acute hospitals, the drive towards centralisation of services, and the uncertainty as to the evidence and need for centralisation, together with the potential impact on hospitals of removal of services following centralisation. And the report was generic, it wasn't meant to be county or region specific, and it was quite a comprehensive clinical review of the interdependencies between a wide range of acute hospital-based services. And the aim was to provide a framework for commissioners' future discussions about configurations of hospital infrastructure. So since that report was published, as we all know, we've had quality standards for adult acute emergency care and quality standards for 7-day services. We've had successive delivery plans for urgent and emergency care from NHSE, seemingly every few moments, but actually annually. NICE have reviewed the best available evidence for emergency and acute medical care, and GIRT have completed extensive nationwide reviews of individual services. And we've also seen acceleration of new and different ways of working, driven partly by the pandemic, together with innovative technologies. And more recently, our sister senates up and down the country have asked if we were going to review the document. So driven by all of these, we have done. And we should also note that pre-existing inequalities continue.
Paul, you've hit the mute button, I think.
Oh, yeah. Can we unmute Paul?
I'll try and unmute him now.
I was going to say I'll do it. I'm sitting there saying, don't worry, I'll do it. Where did you lose me?
Persisting inequalities.
Yeah, so we all know that we have persisting inequalities, so service change is an opportunity to do something about that. And to that note, for people who use this document, we encourage to also look at our health inequalities within the South East region through a service change lens report. So acute care, as we all know, describes the health system components required to treat sudden, often unexpected, urgent or emergent episodes of injury and illness that can lead to death or disability without rapid intervention. And we have some evidence that centralisation for unselected emergency admissions can improve mortality and reduce readmission rates, particularly in older, frailer patients. And key to this, as we know, is the presence of senior emergency medicine and critical care decision makers at all times, and timely access to specialist opinion when required. And the imperative is that both patient and provider are in the right place at the right time for the right intervention, delivered within a time frame that maximises the chances of survival and good recovery. So we've used pretty much the same methodology as before to update the report, and we've also reviewed NICE evidence for urgent emergency care. But as before, this wasn't a systematic evidence review, it's more of a narrative review. And we sought views from the previous contributors to the original report and from clinical leads across the region and from the chief medical officers of both ambulance trusts within our region. And we sought views from national leaders of certain services, including stroke and emergency medicine, and regional and national leads for the perioperative care of the older person undergoing surgery, the POP service, and for virtual wards, and we'll come back to those later. And we used the same 4-level or colour system for describing the strength of the dependencies and revised it accordingly. So the system that was used, to remind you, purple needing to be based on the same site, red, visiting or in-reach services would be sufficient, amber, a patient could transfer to another hospital or site for ongoing care through network arrangements, and green, loose, no or no direct relationship. And in a few cases in the updated report, we've shaded the cell a mixture of red and amber, denoting where services can support each other through alternative arrangements. The minimum time frame of availability for red-rated services is shown as a number within the red box, denoting the hours, i.e. within 2, 4, 12 or 24 hours. As before in the previous report, there are a number of key areas and cross-cutting themes and perspectives that balance the purely service-specific judgments of interdependencies, and we've also reviewed these. So the views of patients and public alongside clinical considerations are obviously essential. And they provide that vital user perspective and balance, and we ensured our patient and public were involved throughout the process. And they tell us that the drivers for any service change should be improvements in patient outcomes and patient experience. They also emphasise the importance of communication between all stakeholders, and they want services as local and accessible as possible, including early repatriation. And whilst a local service may not completely fit the aspirational ideal in terms of outcomes, it may actually be preferable to patients and their families. And we discussed this more fully in another report from our Senate called Putting People at the Heart of Service Change. As we're all very well aware, workforce issues loom large as drivers for change. And again, it's essential that the workforce are engaged and consulted from the outset. And clarity is required as to where the future workforce needs to be expanded, whether that's in the community, in hospital, or both. And workforce planning and training clearly need to align with the ambitions of the NHS long-term workforce plan. But we shouldn't forget that the drive towards integrated care can lead to simultaneous demand for the same workforce in both the acute and the community. And the implications of changing the location of teaching, training and research also have to be better understood, and there are opportunities from greater integration of teaching, training and research and coordination between those providers, but also significant risks if the pathway becomes fragmented through poorly planned reconfigurations. And again, we thought that these areas were sufficiently important to warrant a separate report, and that's teaching, training and research, workforce considerations for major service change, which we've published together with the codependencies report. We know that provision of acute mental health care to patients in acute hospitals also has to be addressed, because many of the people attending acute hospitals with physical health needs may also have mental health needs. And again, this is much more prevalent and often ignored in older people. And Curacy, just by coincidence today, Age UK have published their report on mental health in the elderly. So every acute hospital needs to have a mental health strategy. Ambulance and transport and the function of paramedic services are also critical, and extending paramedic competencies and responsibilities can contribute to pre-hospital emergency care, can deliver enhanced assessment of patients, avoid transfer to hospital, but if hospital assessment is required, then they may enable bypass of emergency departments and instead direct transfer to ambulatory emergency care facilities, to inpatient wards, or to centralised specialised facilities, such as already happens for major trauma, primary PCI and acute stroke. Again, the role of imaging has changed dramatically over the years, with increasing reliance on all modalities for both primary diagnosis and for guiding management. And there's also been a steady increase, again, as we're all aware, in the use of the more complex modalities such as CT and MRI as part of the routine workup of patients across all specialties. And interventional radiology has also become an intrinsic part of modern medical and surgical management. The improved IT infrastructure has enabled improved communication between departments, between and outside of hospitals, and increasingly with patients. And allied to this is the potential impact of wearable technology, artificial intelligence and machine learning on the way that our services operate in the future. And for this revised report, we've also included the two new themes: perioperative care of older people undergoing surgery, the POPS service, and virtual wards. And the POPS service challenges some of the former assumptions around the on-site dependencies, and virtual wards are gathering significant momentum, as we're all very well aware, and we heard in our National Senate's meeting last year. So this is an example of the grid. You're not supposed to be able to read this. It's just for illustrative purposes only. And the rows are the 12 major acute services, which also now include respiratory medicine and non-invasive ventilation. And the columns along the top of the grid are considered to be the supporting services for the rows. At present, we haven't included the POPS service or virtual wards in the columns, but in their narrative descriptions in the document, it should be apparent that virtual wards are an integral part of admission avoidance and or step down from acute hospital inpatient care. And POPS enables greater flexibility in what may be required for on-site support for a number of surgical specialties, and I'll come back to that in a moment. So whilst the dependencies of each of the 12 main services in the rows on the other specialties in the columns were rated independently, there are obviously indirect dependencies that require services to be located together. So if service A requires service B and B requires C, then C obviously requires to be co-located with A. And by looking at services connected in this way, it's then possible to describe the core services that should be grouped together in the same hospital. And it also should be apparent that the front door of the acute hospital and what you let in through the front door will drive what services are required within the hospital. So hospitals with EDs providing an unselected take will have differing needs to those restricting their front door access. And as we know, a number of our acute hospital trusts now have more than one site, and one of these sites may not be set up to receive acute medical and surgical patients, yet still provides major acute services. So an example in our region would be the Kent and Canterbury Hospital, which is where I'm based. We haven't had an emergency department there for donkey's years, but nevertheless, we still are able to safely provide a number of services, such as an acute stroke centre for the region, the regional vascular arterial centre, the regional renal inpatient centre, hemato-oncology, the regional neurology service, and complex operating in neurology, together with an elective orthopaedic surgical centre. All of this despite not having a number of on-site medical and surgical specialties. And in this example, the on-site POPS service is an integral part of the link that enables the previously purple-rated support specialties to become red-rated or even amber. So in the report, we then continue by updating the service-by-service commentaries for these 12 major acute services, the rows from the grids, and how these may have changed in the last decade. And whilst we accept that this in part describes still a very traditional model of service delivery, and that in the last decade there's been a move towards integration of services, for example, within same-day emergency care, which we describe under the commentary relating to emergency departments. Nevertheless, integration of services doesn't obviate the need for access to specialist skills and competencies, and it is this access that the document is also intended to describe. And finally, a word about networks. The red and amber dependencies require clinical and organisational networks to agree and deliver the appropriate care and support for such patients. And the appropriateness of patient transfer for ongoing care is going to vary in different geographical regions, as it'll depend, at least in part, on the distances involved between hospitals. And the Darzi Healthcare for London Review reminds us that the goal for clinical services was to localise where possible and centralise where necessary. And network arrangements help to deliver this goal and to mitigate the risk from centralising services of distance decay, the increasing lack of access to such care the further the patient is from the centre. And this is likely to be much more of an issue in rural counties and regions, especially coastal regions, than in major conurbations. So networks enable best use of scarce specialist expertise, the standardised care. It can improve access whilst minimising need for travel, delays and hazardous handovers. So I'm going to stop there and just leave you with the links to the Senate publications that I mentioned while I was blathering on. And you can find these links in the slides. I think Emily's already sent them through. And they've got embedded links within them. I'll just stop sharing my slides.
Thanks, Paul. So, Emily, I don't know whether you wish to add any more at this stage, or should we just go straight to comments, questions?
No, go straight to questions,
Emily's taking all the questions, Martin.
Yeah,
Excellent.
no, I'm not. Please direct the first one to Paul.
Well delegated. So thanks, Paul, for that canter through what is otherwise an incredibly complex but crucial area, which all senates are wrestling with and trying to understand. I think it forms a useful counterpoint to the earlier two pieces of this meeting, actually, particularly to the arguments for and against centralisation. So can I cast this open to colleagues to offer comments, ask questions? Andrew.
Just a comment, but one I'd highlight. It is this. Start again. I think sometimes as Senates we've been criticised for producing reports which other people were producing anyway, and therefore we've wasted ours and everyone else's time. And I do think this piece of work is a really important exception to that, because it cuts across the different royal colleges, it cuts across the special interest groups, and it does something which other people had never done before. And the proof of that came some years ago when some of us were involved in a review of the big Manchester reconfiguration, which was then taken to judicial review. And the way in which the Senate had operated was given due legal scrutiny. And one of the things that the judge laid great stress on was that over the question of codependencies in Manchester, we had taken cognizance of the South East Senate's document, which appeared to the judge to be a very reasonable and solid piece of work, and therefore we'd done our job correctly by being in line with it. So I think it just is a tribute to the previous document, and I think your current one is a very good update, if I may say so, Paul and Emily. And I would just highlight its usefulness and importance, even when the going gets rough, as it showed itself in the past.
Thanks, Andrew. Paul, I don't really want to add further comments to that.
Well, or just say a big thank you, because I think one of the things that worried us and why it's so important for other senates up and down the country to see the document and comment on it is we wanted to get it right.
Yeah, and absolutely, I completely endorse Andrew's comments and very much welcome you sharing this with us actually in the North. Just as relevant here as it is elsewhere in the country. So absolutely important that this is got right. Faye.
I'm a pharmacist on a research and ethics committee. I'm concerned about the validity of research results using AI if the data of those with protected characteristics or any of those opting out for any reason are not included in the analysis. Couldn't this exacerbate health inequalities?
Yeah, so it's funny you should raise that, because our next piece of work that we started on when we finished this was related, not directly related to your question, but it was to do with patient access to healthcare records, and clearly we're becoming increasingly electronic. So promoting patient access to electronic healthcare records also risks widening the inequalities that you're talking about. And as you correctly say, if people's data isn't there, it's not going to be analysed. I think the beauty of big data is that the percentage of people who don't allow their data to go into these things is small. So when you use big data, you're able to probably adequately correct for that. But it's certainly a point that we take. Thank you.
Could it result in a judicial review?
So that would have to be tested, wouldn't it? I mean, the off the top of my head response would be, I don't think so. But if it, and part of the reason I say that is that the actual numbers of people who don't have internet access in the UK currently. So currently in January 2023, 66.11 million people had access to the internet. And that meant that about 2 million people in the UK didn't. That's quite a small percentage. Clearly, not all of those people who have access to the internet continue to access it. And the other interesting statistic that I love is from Age UK, which is that 30% of people aged between 65 and 74 are not able to perform all of the 8 basic tasks to connect to the internet. And the first one of those, of course, is to switch the computer on.
There are a vast number of
muting the microphone will come in there somewhere as well, I'm sure.
There are a vast number of protected characteristics on EMIS, loads of codes.
Yes, and do you want to say any more about that, Faye, or is that just a hanging
No, it's
statement?
just a comment, really. But it's coming up more and more in some of the research proposals we're asked to look at.
Okay.
Thank you.
So, thank you. Prasanna.
Hello, Paul. From a mental health point of view, I wondered whether your hospital had 2 things which mental health have provided. One is RAID, Rapid Access, thing which was developed in Birmingham. And secondly, the thing called Code 24, which is 24-hour access to psychiatric liaison. Wondered whether your hospital had those 2. Thank you.
So the answer is yes, but that's a qualified yes. So in our trust, we have 3 sites. 2 are acute with emergency departments. And within the emergency department, there's 24/7 access. The one that I was talking about, Kent and Canterbury, I would say less so. So you're quite right, that's an issue, and provision of acute mental health care, as you know, is definitely an issue. And again, it's increasing, it's more of an issue rather in older people. Part of the reason for Age UK commissioning their report. But again, there's some staggering statistics within there, and in that everybody over the age of 65 has had at least one episode of acute anxiety or lowered mood since turning 65. And I thought, that can't be right. And I have turned 65, and I thought about it and thought, well, actually.
So have I, and it's true.
Yeah,
it's true. Do you honestly think mental health is helpful for you? I know the psychiatrist would be very strong in advocating for this, but actually in real life, in terms of research and observed kind of outcomes, do you think it helps?
Do I think it helps to address it, or sorry,
does it help in terms of bed days and untoward incidents and stuff like that?
So undoubtedly, if you don't address the acute mental health needs of someone who is acutely physically unwell, you're going to have an increased length of stay. I mean, we see examples of that all the time. More harm, we also see examples of. So part of my role these days is as a medical examiner, and we certainly see that in the medical examiner service when we're reviewing deaths. So yeah, it's extremely important. I think if I was being absolutely frank, I would say that we haven't addressed acute mental health as well as we should have done within the report, and that's a regret.
Thank you very much.
And we will come on to this a little bit more in the next talk, actually, but I think just to emphasize that point, and I say this as a geriatrician, the mental health of the nation has declined during and since the pandemic, and particularly the cognitive health of older people has taken a substantial bashing, as has the mental health of younger people. So I think these are important factors, and I think the point that Prasanna raises about not just the presence of a service, but actually does it meet the service specifications. In other words, it's quality, depth and breadth, as well as just the presence of a service. So yeah, I'm going to go to Emily first, and then we'll come back to Willie.
Yeah, I was just going to come in on that point, because as Paul says, it is a regret, and it's actually something that was raised at another meeting we were at with regards to mental health in the report. And although we don't really wish to revisit it at the moment, it is perhaps something that we do in the future, and it's just to sort of hold that thought, and particularly mental health colleagues on the call, if we could come to you in the future to look at strengthening that, we'd be very grateful.
Thanks, Emily.
Oh, so I was just going to follow up. It's a real disappointment that one of the national leads that we had no response from when we were doing this was that very specialty mental health. And it was a real shame, because I think it was a missed opportunity.
And I apologize for that. That's not helpful. Yeah, we should have responded much more positively. I agree.
Okay, so work in progress and much to do in mental health, I think, is the takeaway from that. Willie.
Thanks, Paul, for the presentation. You obviously put in a lot of hours to get all of that done, both you and the team. I wanted to ask about application of the document. Then, when we as Senates are being asked to review a major service reconfiguration that involves various services, do we direct them to the document? Not myself, I guess Senate Chair, maybe Martin, directs them to this. And are we expected to see in their submissions that they've made reference to it or considered it? How where does it fit in now that you've done all that work?
Yeah, so great question, and so we do direct people towards it. So we directed people towards the original document. So I was one of the people who was directed towards the original document by my predecessor, who was the chair at the time the original document was produced. So yes, you would expect people to look at it. There may be very good reasons why people don't have the purple rated services on the same site. So as I said, if they have a POP service, then they may well be able to use the POP service as the link. So there are ways in which you can address requirements, but you need to show that you're doing that. So if you first looked at things and you then say, well, we mitigate this in the following way. And I guess it's like everything, and you guys probably notice the same thing. One of the things that's frequently lacking from a case that's put in front of you is data that supports the contention. So part of the problem is that people developing their reconfiguration or whatever they're doing know it inside out. They've been looking at this for years and years, and for them it's a complete no-brainer. And they forget that people reviewing it need to see the arguments that makes it a no-brainer. So you have to have that evidence and that data behind.
Okay, thanks to Paul and Emily for that. Thanks for the hard work as well. Incredibly important stuff. And I guess a reminder to myself to keep this centre field every time we do a review. So more to say. As I say, it's a work in progress, no doubt. But thank you very much, Paul, Emily, for going through this at some speed. You're welcome to stay for the last part if you wish. And I'm going to move us on to the final section of today, and welcome colleagues from We Can Talk, Chris and Natalie, and leads off very nicely from that last piece, actually, because we will be hearing about the importance of co-production and listening to, working with and engaging with people with lived experience. So over to Chris to take us through this next piece.
Thank you very much. Thanks for having us. First of all, I'm a senior nurse by background that has worked across both community and emergency pathways. So I obviously have lots of opinions on everything that you've spoken today about, which has been really great for me. What we're going to talk about today is the We Can Talk programme. Now, some of you will have this within your organisations already, and I am delighted to be joined by two of our amazing young advisors, who are George and Jenny, who will also be doing parts of this presentation as well, recognising that actually none of the work that we do is without any of them, and that's kind of nationally, but also with the team of young advisors that we employ to do some of this work. Could I have the next slide, please? So We Can Talk is a programme that has been running since 2017, and it started with the understanding that professionals in hospitals and acute hospitals don't have the confidence or feel they have the competence in caring for children and young people in crisis. Now, when we talk about young people in crisis, we're talking up to the age of 25, and I recognise that a lot of what you'll hear today will be absolutely relevant for over 25s as well, but the co-production aspect of this programme has been done with 25 and under. So what we have designed is a programme that is supporting change in hospital. I mean, we can sit and argue all day about where the right place for these young people to be is, but the bottom line is acute services are supporting mental health services and community mental health services to provide care and support for young people in crisis. But we can't escape that, and we have to kind of make sure that we're addressing what those young people need at that time when they're in hospital. We'll talk a bit more about the co-production, or Jenny will talk a bit more about the co-production of the programme later. Can I have the next slide, please? So what we do is we kind of work together with our national team, with organisations across the country, to make sure that we share best practice, to make sure that people are working with each other, so not just acute organisations, but working with CAMHS colleagues as well, so that actually what we produce is absolutely meaningful for everybody that is involved in this project. George is going to go through some statistics in a minute, but we are a national programme. We're in 75% of type 1 hospitals. A lot of names that are in this area I recognise, which is great, because what we want to do is to improve the experience of young people in crisis when they come into hospital. But we also want to improve the experience of the staff that are supporting those young people. So we know that staff find it difficult to engage with young people in mental health crisis. They don't know how to talk. They suddenly kind of think that they lose all their skills and ability in a child, or looking after a child and young person that come in with mental health, as opposed to someone that comes into the ward, for instance, with a diabetic ketoacidosis. So can I have the next slide, please? And I'm going to hand over to George.
Thank you, Chris. Hi, everyone. So I'm George, Young Advisor at We Can Talk. I'm sure we'll get into a bit about what that means a little bit later on. But in terms of just sharing some data with you, to put into some numbers. So at the moment, we're currently analysing our 2023 to 24 data. But what you can see on the screen here is really a snapshot of We Can Talk's impact all the way from 2017 through to 23. So all of this data on the screen here, this all includes the in-person training days, sort of pre-COVID, before the training moved online. And then also all of the training impact online, also included up until 2023. And this includes all of our learning modules, which I'll be kind of explaining a little bit more later on as well. And also the core curriculum 6-hour program. So all in all, we can share that We Can Talk has engaged over 30,000 hospital staff in England. But coming to that latest data that we're currently looking at, so we're currently preparing a report for our online platform learning, and that's from 2021 through to now to 24. So through that e-platform impact, we've seen over 11,000 signups from our partner trusts, and that's just for the core curriculum training. That's not including our bonus modules. So of those staff, 5,000 of them have actually completed the full 6-hour program. And of those, we've seen excellent results and feedback from our training analysis. So 97% agreed that it would have a moderate or significant impact on the way they do their job. And 98% of them would recommend the training to their colleagues. So I'm going to hand over to the wonderful Jenny to talk through, if we can have the next slide, please.
Thanks, George. Hello, I'm Jenny. I'm another young advisor, and I am a northerner as well, so it is very lovely to be here today. So yeah, I'm just going to talk a bit on co-production. So co-production is at the heart of what we do at We Can Talk. It's at the heart of everything we do, from like the training modules to the co-produced projects that we make, and just basically everything. So co-production, I'm just going to talk a little bit about what it isn't, what it is, and what it means to us. So co-production isn't just a survey or a feedback form. It's not something that's already in place that you want someone to give feedback on. It's not an imbalance of power. So, for example, your test group might be young people, but their insight should be seen as equally valuable as any other person or adult that's giving their feedback as well. And it's not just hearing from one group over and over again. So for us, it's the co-delivery and the co-design of a project and a campaign. It requires professionals and organisations to listen to the voices of the people who are in on the project and who the project is based around, or the campaign, and to hear their opinions and to make sure that it's a collaborative experience that respects and recognises each individual and their opinion and their thoughts. And it brings us an opportunity to build these relationships. So, for example, it could be between patient and healthcare professionals. So co-production allows for a diverse range of voices to be heard, which is essential, as it allows for the chance to create positive change that is long-lasting. Co-production transforms patients, pupils, parents and carers into participants and agents of change in public services, education and organisations. And by embracing co-production, it acknowledges that things are not fixed yet, but everyone can be involved in that chance to make change. And I think it's important and beneficial to hear everyone, and it increases inclusivity and encourages people to really reach out as well. Please can I go to the next slide? So these are our principles. They are also at the heart of everything we do, as are obviously is co-production. So I'll let you read through those. I'm just going to kind of talk about them a little bit. So all of our training is underpinned by these co-produced principles. They were co-created with young people who have used services and the staff that work with them. You'll see a bit in these principles how like later on in these slides that how all these things really do underpin our work, and it is involved in everything that we do. So we talk about the elephant in the room in our training, which you might hear some more on after, and that often is talks around suicide and self-harm, but we don't shy away from those kind of conversations as they're important. And talking about risk doesn't increase the chance of risk, but having these important conversations can help a young person to be open with you as professionals. And I think in particular, number 3 and number 5 here of these principles are kind of what they're referring to. So I'm going to pass you on to George for the next slide, please.
Yep, thank you. So in terms of the training, what it actually looks like when you log in, when you sign up, when you want to start getting engaged with it. So all throughout the training, you hear from clinical experts, you'll hear from nurses, mental health professionals, and young advisors, young people like me and Jenny. Throughout the training, we really are with you from start to finish. In terms of usability, you can. In terms of using the platform, you can progress through the training at your own pace. There's dedicated learning modules on kind of different topics to kind of build your knowledge and understanding as you go through. We offer CPD certificates for each of the modules that you complete, which obviously for nursing staff, for instance, can be used in every validation. So in terms of the core curriculum program, being the 6-hour program, so that's made up of 5 modules, individual modules, and it ends on what we call the elephant in the room module, which is basically a role-playing game in order for trainees to apply their learning throughout the program into a realistic sort of choose your own adventure scenario that's featuring actors as a mental health professional and then a young advisor as well, as a young person in crisis. So it's kind of staged, but it's a role play adventure, so you can kind of choose phrases that you think you would use in that situation, and you can see how it kind of reacts, and you can learn from that. In terms of the 3 modules that are available to absolutely anyone who signs up for free, those include the fundamentals of compassionate care. We've got a module on well-being, and then our most recent module that we created is the ambulance module. So just for an ambulance module, so we created this to address the significance of the journey, from arriving on scene to the back of the ambulance to the transition into hospital, making the experience better for the young person in crisis, the ambulance staff, and also the hospital staff when the young person arrives and they're handed over. And just kind of personally, I have to say that I just absolutely jumped at the opportunity to be involved in this particular learning module. and co-produce it with the team. Just from my own experiences, fortunately, I can say that I've had really positive experiences with ambulance staff in mental health crisis. So I kind of wanted to contribute that to the project, kind of on balance with obviously other people who have had less than positive experiences. But yeah, it was just a very rewarding module to be involved in personally. Could I have the next slide, please? Thank you. Okay, so it doesn't stop there. So we're going to talk about quality improvement. So this is another part of our kind of offer that's very much co-produced. So a part of the kind of onboarding process of trusts into getting access to that 6-hour core curriculum program, we ask the trusts that we're going to work with to identify local project leads from their hospitals, and they basically become our kind of champions of the brand and the training in their workplace. So we really encourage them. We implore the project leads to spread as much learning and awareness around their, their setting as possible. We reward them. We give them rewards for achieving certain milestones in the number of sign-ups from their trust. So a little bit of a healthy competition. So since that moving online in 2021, we had project leads previous to that. But just in terms of what we've done online with them, so we've run 4 cohorts, and they each last 6 months of those project leads. And within that, we've delivered over 100 hours of training with our project leads. And that includes co-production workshops, support sessions with the We Can Talk team, including young advisors such as Jenny's, myself, and the wider network as well of young advisors. At the end of the program, and we'll get into what the kind of project looks like in a minute, at the end of the program, probably our favorite part of it, I guess, is we have a celebration event. So that's where the project leads individually present what we've achieved with them over that 6 months and their co-produced projects. And they present that before their peers, their other project leads from all around the country, and also to the audience of senior leaders in the NHS and representatives from NHS England as well. So it's really kind of like a big party, I guess, where we celebrate our co-produced projects and what our incredible project leads have achieved. This photo here, I put this photo in because it's just my favorite. It's my favorite photo. We get lots of photos from our project leads, spreading the program. This is my favorite photo. So this is Becky from North Tees launching the program, engaging her colleagues, bringing her colleagues, fellow nurses and other hospital staff into the We Can Talk community. So this photo would have been taken at the start of her time with us, where they do a launch event. So we send them a roller banner, we send them all sorts of little goodies to kind of help get them set up and kind of spread the love, stickers and things throughout the hospital. So that's the kind of just an intro to the quality improvement bit. So for the next bit, if I could have the next slide, please. Just to give you an idea of what this all kind of means, what we actually do with them over the 6 months. We've just picked out a few of our projects, and this is out of the dozens of projects just like these that we've done. It was very difficult, but we managed to pick out a few favorites. So I'm just going to talk a little bit about, I'll give you the story behind this, my favorite quality improvement project that I've worked on. So this was with Michael from Nottingham Hospitals Trust. So he joined us back in October 22 with another cohort of project leads. So over the course of 6 months of the program with them, attending our project lead sessions, webinars, educational webinars run by the young advisors, and he did a lot of his own homework and research as well. He produced and implemented in his hospital this community board, which kind of provides information, resources, activities, and it's really for everyone, from the children and young people in crisis, through to their parents and carers, and it's also really helpfully utilised by the hospital staff themselves. So in terms of the project lead kind of timeline working with us, so right at the start when we have our first session, we ask them to identify areas for improvement with regards to caring for children and young people in mental health crisis. And we ask them to come up with 3 really big, as imaginative as possible, like ridiculous ideas to create positive change in this area. So Michael did just that. He brought us 3 big ideas, about 1 million small ideas, loads of enthusiasm. And then we did what we call our Dragon's Den session in front of a panel of young advisors like Jenny and myself. Basically, we kind of act as if we're like investors, and the project leads are kind of like entrepreneurs with their ideas. And we kind of, narrowed it down into what could we do with them over 6 months and within the time constraints and the kind of budget and everything. So this began this design of the community board, starting from scratch, with a list of ideas that we discussed with him. He then went away and he did loads of digital designs like this one on the left, and he kept sending them to us. And then myself, Jenny, Marley, Becca, all the other young advisors, we all come on, we comment on it, we talk about things like, oh, this color maybe wouldn't work, this bit, this could be more accessible. We kind of have a back and forth relationship over the months, and in the project lead sessions as well. And then that eventually led to, we gave it our stamp of approval as young advisors when we were happy. And then Michael, went away and he produced the final display, which you can see here on the right. So it was really clear how much he really valued our perspective as young advisors, how we do co-production. I think that shows here, in the final result. You've got QR codes on there for extra support for young people. There's all sorts of activities and things. But what I like most personally about this project, this board you can see here, is just the fact that it is for the community, as is in the name. It can be used by anyone visiting, staying on the water, even just passing by. All sorts of activities and things on there in relation to mental health for children and young people. And Michael really encourages his colleagues to, complete the training. He continues to be a champion for us, and he encourages them and trains them to use this resource, this community board, and all the things that come with it in order to complement their practice. And he really champions, the voices of children and young people. And it was so rewarding, I'm sure Jenny will agree, to be one of those voices in the team of young advisors that we can talk. And I've gone on way too long talking about my project, so I'm going to swiftly hand it over. If we can have the next slide, please. Jenny's going to talk about one of her favourite quality improvement projects.
Thanks, George. Yeah, so here you can see, so on the left was a before, and then the three images? Yeah, on the right is like a after of how this project has grown. So the problem with this one was that Tabitha and James identified that there was high areas of admission in certain areas of the hospital, and after a staff survey that they asked, staff agreed that they would also lack some more training. So the project idea was to make an emotional wellbeing observation chart for young people to fill out with staff, with some wording changes on the sheets, and we helped to co-produce those questions so that they would be more comfortable for a young person to answer. And then we also co-produced a traffic light system, which I think you can see, of things things that they would want to avoid, such as certain topics or words. In some instances, this could include words that maybe they would want an alternative word to be used instead, as it could be a trigger. It included a section for things like how they may show signs that they're struggling, so staff could be aware of these things, sort of a bit like a safety plan. And then a section as well to add things that can help when they're struggling in this way or in a crisis, which could be quite useful. We then also discussed how some people may not be able to verbally communicate if they're in a crisis, or they may have speech difficulties. And we discussed how we could communicate with people like that if they needed to communicate, which obviously everyone does. And we first thought about emojis, which you can see at the bottom. And they could be maybe circled or used in some way. But that transformed then into cards, which the hospital had implemented. Like they'd been given these cards, and we helped look at the cards. You can see them very tiny on the third image, and said like, well, what if there's not enough range in there? So blank cards were also added to this card pack as well, so that young people could then add their own emotions if these cards didn't cover how they were feeling. So that could be things like anxious, proud, excited, or scared. Because obviously there is a wide range of emotions when someone is in hospital, and they could be proud that maybe they'd had an injection and they weren't so worried about it, or they managed to do it, those kind of emotions. That not everything is so negative all the time. So the final result is what we're looking at on the three images. And they were looking to implement these tools in obviously young wards where young people were, but also in maternity wards as well, because it was recognised that there was young people on the wards in like maternity wards as well, which is something I hadn't even considered, that would obviously maybe struggling through pregnancy or after birth as well. So what I like about this project is that I love the cards in the pack. I think it's a great way for young people to be able to communicate with staff if they feel as though they can't verbally communicate, or if they aren't able to, and they may need other forms of communication. It's accessible for them. I love that it wasn't just children's wards that were considered, and we often forget that young people will be on other wards, and maternity wards. Like I said, I didn't even think about that. I love that the sheet can be filled in with staff, that it's to do together, because it has more accessible questions, and I love that there's a part for a young person to fill in on their own, because they can fill in as much or as little as they're comfortable with. It's giving young people a voice when they may feel they're most vulnerable and helpless, and it's giving the young person to have the opportunity to talk about the care that they receive as well. So with that, I'm going to pass on to Chris.
Thanks, Jenny. I will stick us to time, even if I race through the next slides. So apologies for that. Can I have the next slide, please? Oh, sorry, yes. So that's this is the project I picked, and I picked it because of its uniqueness. So this is from a project lead that's on the Isles of Scilly. So going back to the centralisation conversation we had at the beginning, they don't have a type 1 emergency department, which kind of blows my mind that they are literally isolated by bodies of water and they don't have a fully functioning type 1 A&E department. But what they do have is a lot of children and young people in crisis. So what Simon has done has created a full mental health assessment for those young people, because it doesn't really matter what the projects are. It's about that engagement with young people when they're in crisis and how we support them as staff, and starting those conversations and being confident in those conversations, especially when we're asking about risk and suicide, is really important. And Simon's done an incredible job kind of introducing that. So that's why I picked his project. Can I have the next slide, please? I'm just going to quickly talk about some of the data that we've just recently got hold of, and you'll have to excuse me because I'm not a data analyst, and usually our data analyst presents this part. But what we do is we have quite a robust assessment process for learners going through the training to kind of gain that understanding and confidence of the training before and then afterwards. We've also then gone back to those staff kind of after 6 months and more to see actually what they felt now. So if we can go on to the next slide, please. So we asked them about absconding rates, we asked them about security call-outs, we asked them about well-being, their own personal well-being. And what we found is, and this is all self-reported data, and it's a very small cohort, it was 100 that we started with, that they reported a 40% reduction in absconding. Now, one of our project leads actually did a triage project for emergency care and reduced their absconsion rate from 0. So about 90% of the children and young people that went in asking for mental health support to their A&E department absconded, and she got that down to 0, which is a phenomenal kind of result. But that's also replicated across the children's wards, because actually staff are going in to have those conversations. They're validating those young people. They're not being treated as, you know, you shouldn't be here, you should be in a mental health unit, we're not equipped to deal with you. So 40% reduction in absconding, a 43% reduction in security call-outs. And for us, that's a really big factor, especially, you know, for me, looking at my background in emergency care and paediatrics, is that actually, you know, if we call security, we've kind of failed. It's a bit like calling an ALS team when actually you've missed all the signs to kind of support that person to stop them from going into cardiac arrest. Because security are kind of like the last resort, aren't they? We can't handle it, let's call security, and they come in kind of, you know, guns and whistles blazing. a lot of our project leads have encouraged the security teams to do the We Can Talk programme, and the feedback that we're getting from them is actually they respond to those incidents differently as well. What staff have also reported is that there are less sick days that they are taking. So those incidents that cause real moral injury around having young people who are so sick on the wards from a mental health perspective, not being able to manage that and something terrible happening, that internalisation of I should have done better, actually this programme helps with that. So there are less of those incidents, which means there are less sick days. And that kind of relates, if we take that to the amount of people that have completed the whole training, is an eye-watering kind of set of statistics for us to be working with. If I could have the next slide too, please. So we also asked them about turnover and retention. So how many people have thought about leaving their jobs specifically in relation to looking after children and young people with mental health issues? Actually, there were a lot of people. They felt that they weren't supported before they did the training, that they kind of didn't have the equipment or the knowledge or confidence to deal with these young people. And what we found is that actually that number has also reduced. So 30% of staff that do the training feel that less likely to leave because of that. And if you add in all of the recruitment costs that it, you know, advertising, interviewing, you know, going through the whole recruitment process, which is never easy within the NHS because we have to jump through lots of hoops to do that. Actually, that's also an eye-watering amount of money that we save. If I could have the next slide, please. So what we are looking to do in the next 3 years is to get into every type 1 emergency department. Now, we say emergency department because that's where the majority of young people start their journey after they've come in by ambulance. But that's not that we're not recognising that there are paediatric services off-site that also manage these young people. So if you have an organisation that has a type 1 hospital, the rest of your organisation also gets access to the programme. And that's regardless as to what grade you are, what discipline you are, kind of you can be the cleaner, the porter, the consultant, the nurse in ED, a paediatric nurse. It doesn't matter who you are. This programme is suitable for anybody at any level and any grade. So we want to be in all of the hospitals within type 1, because the more we educate and train people how to manage young people, actually the better the experience is for everybody, and the financial impact that has is also better. I'm going to hand over to Jenny now, just for the last slide, because I think it's really important. And as you've kind of heard, the passion that we have about working with young people and what they think and what they want from the services that they access, we're going to leave you with these. Jenny, over to you.
Thanks, Chris. Yeah, so it's just a few top tips just to take away. I will try to be as quick as possible. So don't dismiss us. Please actively listen to us and our concerns. If we're in crisis or we're desperate for help, we may feel like other avenues have been exhausted, so please listen to what we're saying. Don't assume it will pass. These thoughts, no matter if they are short-term or long-term, can be scary, and they might be reoccurring for some of us too. Each case is obviously different. Please don't tell us how we feel. You may have similar experiences and thoughts about situations, but sometimes it isn't helpful to hear when you're struggling in a crisis. As I mentioned, everyone is an individual, and my experience, even though it might be similar to yours, will be different in some way. Please don't speak on our behalf unless we ask you to. It's so important that we feel comfortable in advocating for ourselves when we can. Of course, if someone asks you to maybe talk to a parent or carer to help explain something from a professional point of view about what's going on, then that's totally different. But if we can have the chance to speak on our own behalf, it's empowering to us, and it also lets us have control over our care and the conversations that we have around that. Please don't say that you'll do something and then not live up to the expectations. And we know that obviously sometimes we can't do certain things, and you may have mentioned one thing and it might not be possible later on down the line. But explain to us why that is if possible. It's very disheartening to hear that you'll receive X, Y, and Z and then for it not to happen. So that happened to me, where I got told I would be referred for a certain antidepressant and it would be put on my record, and then it wasn't. So when I went to my GP to get it, it wasn't there. So I didn't know what the name was or anything, and it can be quite frustrating and upsetting to try and go through that process again. So a way to avoid that next time would have been if they could possibly have written that down for me, so that if that had happened, I could then go to my GP and say, oh, this is what it was. Positives, do listen to understand and not respond. We talk about active listening a lot, but having someone who wants to listen to us and is actively listening to us can make us feel more comfortable and help us open up to you. Stay calm. Even if something we said may worry you, staying calm while you're with us can help us. If you start to get panicked or worried, it's okay to take a few minutes out and to maybe raise a concern with someone, because obviously your mental health matters as well. But staying calm while you're with us can help us feel more relaxed too. If we're in hospital, it's already a stressful environment for everyone involved. So being chill in front of us as much as you can help us try and settle in and make us feel more comfortable to have these conversations with you and be more honest. Stay compassionate. We appreciate that you must hear a lot of stressful things at work. Please be compassionate with us, as what we're going through is obviously quite stressful to us. Please take our situation seriously. Young people often find that they aren't taken seriously in many areas of our daily life anyway. So it's really important that we're taken seriously, and what we tell you is taken as serious, especially when it comes to things like self-harm or thoughts of suicide. Please do validate our experiences. Tell us that you appreciate us sharing that information with you, and validate our personal experiences as well. And please involve us in our care planning. We may not be able to have a say in everything, but allowing us choices over our care when possible gives us autonomy over ourselves and the care that we receive. It allows us a chance to use our voice and, like I mentioned before, advocate for ourselves. And this means that we're more likely to stick to a plan if we've had help creating that plan with you. I'm going to pass you on to Chris on the next slide, please.
Thank you. So these are our contact details. Obviously the slides are going to be shared. Please get in contact with us, especially if your organisation doesn't have the programme yet. We're looking to get funding from NHS England for the next 3 years, having finished this 3-year contract. Obviously that's kind of a bit up in the air with the merger with HE and NHSE, so but we are looking to deliver this everywhere. And thank you very much for having us. I just have to apologise because I know Jenny and George have to run away to record another session for one of our other training platforms. So yeah, otherwise I'm happy to take questions.
Thank you, Chris. And before Jenny and George rush away, thank you to both of you for incredibly helpful presentations. Really, really insightful stuff. And your slide, Jenny, I would say is an absolute masterclass in engagement in how to get it right. So thank you so much for taking the time, and do feel free to drop off the call, but really appreciate you joining us today. There's lots of comments in the chat, but I'm going to hand over to colleagues to offer any comments or questions, if there are any, to Chris. I think you stunned them into silence. Jonathan.
Yes, I abhor a silence. Sorry. No, great presentation, and just to thank you. And I think that should be obligatory learning for everyone when they get beyond their younger years, because as I approach the end of my career, I'm conscious of how distant I've become from my younger patients who I interact with regularly, and trying to keep that trying to narrow that gap is really important. And that last slide with those 10 points on the do's and don'ts, absolutely fabulous. So thank you.
Feel free to share them. well, like all of our training and everything is free to use. So the education framework on the website and anything we have is absolutely open for anyone to use.
That's great, Chris. I'll do my best on that. Thank you.
And we will circulate slides to all assembled here afterwards. I was going to offer my own comments on that. Just the one thing, kind of linking this talk to the very first talk, the same point made from completely different perspectives. And saying you'll do something and then not living up to expectations kind of translates onto big centralization programs and then right the way down to the lived experience of younger people experiencing hospital care. And those two things are necessarily linked, I think. So, Prasanna.
Hello, George and Jenny. I wondered whether you train in this thing called suicide safety plans, which is a co-produced document between a mental health worker and a young person, about what to do if they become, they have emerging suicidal thoughts.
So I'm really sorry. I think George and Jenny have dropped off, but I'll do my best to answer on that behalf. So from a personal experience, their own personal experiences, I can't answer for that. The projects that we look at are around, so the We Can Talk project specifically is not about helping mental health clinicians master kind of what they do, because they are the experts in this field already. But what the acute staff need is some help and support in addressing these issues, and that's what this team does, is they help the acute staff in acute hospitals manage something that they feel is outside of their sphere of confidence and competence.
Thank you.
Any more thoughts, reflections, comments? And if I could perhaps just cast it more widely across the whole session this afternoon, before I try and sum up what we've heard. Are there any other things that colleagues wish to return to? Any additional comments or thoughts? If not, what I'll do, I'll draw us to a close, but I just want to make a few thoughts and observations, and then to offer my thanks. I think it's been the most incredible session, actually. Just drawing together a whole range of different presentations, but with some very common themes, as I say, focused around 21st century health services transformation. John's presentation at the top of the meeting around centralisation and the challenging nature of evidence around that and the assumptions that we can apply is incredibly important, I think, for Senate work going forwards. And then getting ever increasing insights into the opportunities and potential risks presented by Catherine and Gordon around digital opportunities and transformational things, which I think, love it or hate it, digital is here to stay. There's a huge opportunity there for research and better understanding and evaluation of these interventions. And I think we heard really quite resoundingly positive comments, particularly from primary care colleagues. And then leading off that, the interdependencies framework, amazing work from the South East Senate, as always, and helpful, I think, for us to recite ourselves on the refresh framework, and I guess that will continue to be a work in progress. And I think particularly the strong views expressed by colleagues around mental health were then emphasised and brought to life through Chris and colleagues, George and Jenny's pieces around engagement, co-production. And I am struck by that last presentation that many of the principles explained there are very, very translatable. One of the things that senates thrive on is the information that we receive through engagement with a much broader group of people and service users and people with lived experience. And I think as we go forwards with Senate programmes of work, it's increasingly important that we do listen and understand people's experiences if we're going to achieve better outcomes and retain high quality healthcare in the NHS across the country. So I'm going to say thank you to all of our presenters today and the amazing quality of their presentations to us. As I say, we will share all of the output from today. Thanks again to the Senate management team for the North West Senate who have behind the scenes kept me on track, which is no minor feat, and coordinated all of this today. And then finally, thank you to all of those who have given up the time this afternoon. I really do hope that it's been useful to you. We continue to provide these development days for Senate members, both council and assembly members across the north of England, and thank you to my colleagues both in the northern England and the Yorks and Humber Senate. And I did neglect to say that Kirtik Patel was on the call. I think Chris was unable to join us today. So thanks Kurt for joining us and representing the Yorks and Humber side. So finally, please do continue to engage with each other, and I think one of the strengths of the Senate, from my own point of view, is that we as a group of interested, motivated individuals with expertise have so much to contribute back to the health service. It's reassuring to know that right up to the national leadership there is continuing support for what Senates do, and I think it was a point made by one or two colleagues today that the value that Senates add through their independence and objectivity does exceed that of other bodies who may seek to offer advice and support transformational programmes, but may be somewhat more self-interested than those around this particular table today. So thank you to one and all. Good to see you all, and we look forward to continuing with these sessions into the future. Do have a good and happy rest of today.
Thank you very much.
Thank you.
Bye-bye.
Take care.
Thanks.